Nox back in the day.
So maybe, sorry for interrupting you. So maybe take me there. What is an ordinary day for a young, black, female South African doctor in internship?
It was so full that we were delivering babies on the floor in the corridor. Your patients are delivering, there's no water. I realized that no matter how well-meaning I might be, I'm limited now because of these elements that I personally can't control.
Was it in med school or was it an internship when you saw your first patient dying?
Medicine and health goes beyond prognosis, diagnosis.
Exactly what I'm thinking.
I did 24-hour.
3, would you become a doctor in the South African system again? South African doctors typically follow a 2-year internship process. After that, they've got a compulsory year of ComServe. Some of the public sector issues we're currently facing is severe pressure of staffing shortages. We've got post-community service doctor unemployment, burnout, infrastructure constraints, language barriers, and unresolved implementation and confusion when it gets to NHI. Dr. Nox, welcome to the studio today. What does it really mean to be a South African doctor in the current market?
So what it means to be a South African doctor for me, and I have to personalize it because I think from my perspective, I'm a woman, number one. Number 2, I'm black. Number 3, I think I'm fairly young as well. So there's also that sort of demographic that I'm occupying. I think South Africa, understanding our sort of backdrop is very critical. Understanding that we are so diverse in terms of ethnicity, in terms of language. We are even diverse, I think, geographically as well.
Yes.
Is very important to understand the experience of a doctor through that lens. So what it means to me is, number one, we have such a responsibility. So we know that 84% of our population is in the public health sector, and that's where we operate as doctors when we are in ComServe, when we are in internship. And a lot of the times we are working in public hospitals that are constrained, like you said, in terms of resources, in terms of infrastructural issues, in terms of, I'd even say, governance issues that are there. So working as a doctor in that space already, I think you have to understand that you might have to stretch yourself beyond just that I'm wearing a stethoscope and I'm treating illness. I have to understand the socio-economic structures that are in play for my patients.
So maybe, sorry for interrupting you. So maybe take me there. What is an ordinary day for a young, black, female South African doctor in internship?
I think an ordinary day, it just depends, again, on what facility you're in. But most of the time, we start quite early. So I remember when I was in Charlotte for my internship, when I was in surgery, for example, we would start at 6 o'clock.
Only for surgery, 6 o'clock, rest of the rotations?
Some of the rotations would be 7, 8.
Okay.
It all depends on what the unit needs. I mean, if you think about it, we weren't supposed to start at 6, but because of the need, the shortage, and we knew that we had a high volume of patients, it was better for us to start early so we could
Is
get the day going.
Is this a Charlotte thing or is this across the board, maybe potentially when it gets to surgery?
I think when I've spoken to my friends who are interns, it's across the board. It all depends on what that specific unit needs.
Okay.
Yeah, you would start firstly with ward rounds, so you'd be with a consultant. If you're lucky enough, it also depends whether you're in a tertiary, whether you are in a secondary or a primary setup. So with me, I was in a tertiary, so we did have consultants or specialists that were in the hospital. And pretty much you would do your rounds. So that basically means is you go patient by patient. There are certain things that need to be done for that patient. For example, taking bloods, maybe ordering x-rays, things like that. That would be the responsibility of an intern. So very administrative tasks as well, paperwork, lots of that. And then after that, the consultant would go off. Maybe they need to go see certain patients. And then as interns, you would be basically manning the ward for that day.
So tell me, administrative work versus clinical work as an intern. 80%, 20%, 70-30, how would you?
For me, it was a 70% administrative, 30% clinical work for when I was an intern.
Can this be that it's maybe potentially because you worked at Charlotte? Do you think in some of the smaller, let's call it smaller community hospitals, it might be different, where it's the flip side, it's maybe 30% administrative and 70% clinical?
Definitely. I can backdrop it to my ComServe time when I was in Limpopo, where I was working in a district hospital. No specialists. You were the senior on the floor. So that takes a different sort of percentage, where maybe 80% doing clinical work, 20% you're doing administrative. And mind you, we didn't even have interns at the time.
Is it?
Yeah.
So you were the intern and the ComServe?
And the ComServe and the specialists.
Is there a lot of hospitals in the rural communities that don't have any interns? And why?
I think yes. Remember now, a hospital, in order for them to take an intern, it needs to fit certain guidelines for the HPCSA to be accredited, because there's certain rotations that you have to have, and you also need intense supervision because you need to be competent. So you can't just, be an intern, rock up and just work clinically. You need guidance, you need people to teach you, so that you're ethically sound in terms of your work.
Okay, so some of the hospitals do not offer those, let's call it check boxes. And
100%.
hence there's no interns.
Absolutely.
Take me back to Nox in grade 10, grade 9, grade 11. Was medicine your dream? Who were you back then? And why medicine?
Nox back in the day, grade 8, grade 9, grade 10, I think she was a very uncertain lady just in terms of what career prospects she would go into. I always had sort of like a dual mentality. I wanted to do something in biology, something in health. But then I also had a very artistic side to me. So I like to talk, I like to perform. And one thing that I think cemented me going into health was my desire to be in the forensic space. So when I was 8 years old, I used to watch this show called Forensic Files, which dealt with forensics. And, I remember thinking, whoa, this is the world that I want to be in. I just didn't know that you could go through the medicine route to get into forensics. So by the time I got to grade 10, I was certain that I wanted to do medicine and I wanted to be in health, after doing some sort of research in terms of forensics, in terms of what are the career prospects. And also I knew I wanted to be in a career path that was in shortage in South Africa. And when I checked the internet, medicine was one of the top 3 shortages. So I said, I think that's where I need to go.
Okay, so very niche, very focused, and hence you made the decision. I want to maybe flip that over to say, if there's someone watching this episode today, or maybe like someone have children that is in grade 10, grade 9 watching this episode today, that might be overwhelmed, confused. There's so many options. I remember back in the day when I sort of did those geometric tests that shows you what you can become. I could literally become anything, from an actuary to a teacher to a coach to literally everything. So you still stay a little bit confused because there's all these options available to you.
Yeah.
How would you help someone that's got that sort of confusion listening to today?
I think like what you said, the first thing is, if you know that you're uncertain, let's see what resources the school has to provide career guidance. So some schools, like you said, will have geometric tests. I remember with us, we actually went to university because I'm from KZN. So we went to UKZN University, and they had like a career counselor there that you could talk to and sort of like get an idea just in terms of your personality, in terms of what are the things that you like, what might fit best. But like you said, you could find yourself in a situation where you probably will flourish in different or multiple career fields. So I think from there, also understanding that you can really change as you go along. And I think there's this pressure by grade 10 that you need to have figured it out and you need to know exactly where you're going. And I wish I personally didn't have that pressure on myself that I placed on myself as well. I think understanding that if you know roughly that you're more inclined to sciences, health, then make sure that your subjects cover you for that, so that when you go to university and you want to choose which modules that you want to go to, then you're covered. If you know you're an autistic person, cover yourself for that as well.
Awesome. You mentioned briefly you had a career counselor assisting you. Did you do any shadow work in the medical space?
Yes.
And do we have options in South Africa available? Let's say a grade 11, grade 12 person can actually shadow.
Yes. So I actually did do shadow work in grade 11. Was part of one of our modules or subjects that we had to do that, an elective, I think they called it.
Okay.
So I did it with a local GP, and I did not like it. I did not like it because I was just like, wait, do you mean I'm just going to sit at a desk and just see patients roll in one by one? I wanted to be more hands-on, something more biology-based, which is why I had that affinity to forensics. I think a lot of the times they're not clear pathways as to where one can go when it comes to shadowing, But the classic is really just knock on doors. You can ask the institution themselves, whether it's a facility, whether it's the doctor themselves, if I can shadow. And usually they're quite responsive and they're willing to take you on.
I think the cool thing also is you knew GP is not necessarily for you. But that's the thing about medicine is you can wander into radiology, maybe gynecology, pediatrics. You can find a niche within the bigger sector.
For sure.
Which is something that speaks to your need.
Yeah.
Nox, maybe that's Nox grade 10, grade 11, grade 12. You did med school. After med school, during internship, I wanna talk a little bit about a day, potentially, that changed you. An event that changed you forever, whether that's for the good or whether that's for the bad. And maybe take us to that day. Take us to the ward, the people that were around you, what you saw. What was that day?
Okay. The day that changed me, and I would rather say a rotation that changed me, was my obstetrics and gynecology rotation. So when I was in Charlotte, unfortunately that year, the hospital had a fire. When I was 2 weeks into my obstetrics and gynecology rotation.
I remember the fire, yeah.
Right. So what they did was, because we couldn't operate at the hospital, they then basically dispersed us as interns to other facilities in Johannesburg. So in my internship, I actually ended up working in, I think, more than 8 health facilities that I typically wouldn't have. So I worked at Bara, I worked at Bertha, Charlotte, Edenvale. These are clinics that I wouldn't have worked at, even Rahima Musa.
Wow, what an experience.
What an experience. I still really highly value that experience because I really got to see, obviously working in tertiary, you're limited because there is a level of efficiency that's there is a level of infrastructure and but getting to work in these other sort of facilities really opened my eyes to some of the issues that we're facing in public health. I'm not sure if I'm allowed to name names, but I was in a hospital that was in a colored community, but that serviced quite a variety. So it serviced Black South Africans, colored South Africans, and I also think foreign nationals as well.
Okay.
And when I was there, it was so full that we were delivering babies on the floor in the corridor. So that's number one. And also they had issues with the piping and plumbing of the hospital. We had no water. Now imagine being an intern, trying to do Caesars without water, for me at that time, I was so stressed. I had even a runny tummy. So I had to go to the toilet. There's no water. Your patients are delivering. There's no water. What a disaster.
Understaffed as well? Or?
Understaffed. Absolutely understaffed, because as an intern, I was running to theatre. After theatre, I had to run and quickly see patients in sort of like their casualty. And then I had to also deliver some ladies' normal deliveries in the labor wards. So it was really, really hectic. I've never, up until today, I've never delivered people in the corridor.
Is that a seasonal thing in that hospital, or is that an institutional issue that we face?
I think it was an institutional issue.
Okay.
That hospital, unfortunately, was not well upkept. So these plumbing issues were sort of like symptoms of a deeper issue,
okay.
In terms of governance, in terms of upkeep, in terms of, understanding what they need in order to reach their KPIs as a hospital. So it was really, really tough. And I think for me, it felt good to be able to service people in such a strange situation.
Yeah.
But at the same time, I understood that maybe another doctor might not be so lucky and have a situation where maybe a mom complicates or a baby complicates because of the dynamic that's there. And obviously that can do a lot to you mentally.
Yes.
Yeah, it can harm you mentally.
Maybe on that note, what took something from your personality that day that you had to fight over the let's call it the last 3-4 years to get back? Did you get into, I don't want to put words in your mouth, but did you get to a stage where it was like, knowing you personally, you're someone with a lot of empathy. Did it get to a stage where it was like you now had to start getting the job done, under harsh circumstances? I don't know. Was there something?
I think it broke me. I don't know if that's a personality change, but it broke me because I realized that no matter how well-meaning I might be, my intentions as a doctor, I intend to, stick to the Hippocratic Oath. I intend to provide a service. I intend to provide it with compassion. I'm limited now because of these elements that I personally can't control. And that broke me because I want to deliver these babies well, but now there's a potential that these babies can be harmed, these mommies can be harmed because of something that is well beyond my control. And that really just, still today, it messes me up. Yeah.
Can imagine. Have you ever sort of had to make peace with potentially losing someone or not being able to assist someone due to the lack of infrastructure, due to the situation in some of the government hospitals, knowing you did everything you could, yet you might be in that conflicting view that you always feel you could have saved that person, you could have pulled this person through. Maybe also a situation that happened where you did pull somebody through, irrespective of the situation.
Yeah. I think in South Africa, doctors, especially in internship, are going to have many moments where they feel like this is something that they are so happy they did because of the situation. It provides so many opportunities for you to rise up and step up, where typically maybe things will be easy provided for, but now you have to sort of push yourself a little bit further, and that can provide a lot of satisfaction. But the flip side of it is that it comes at a mental cost. Because I know with me already when I was an intern, I said, you know what, I need professional help. I need to talk to someone about the things that I'm seeing, because also we were in the backdrop of COVID at the time. So I was just seeing death at an exponential rate. And I just said, you know what, I just need to talk to someone professionally to make sense of this very different environment that I had a completely different picture of when I was the year prior, a final year medical student. It's a tug and pull a lot of the times. You can feel you're making a difference because let me use an example. I remember when I was in surgery. Surgery also provided a lot of those sort of like, I would say, existential moments for me, where there was a young lady, I think she was in her 30s, and she was terminal cancer. I think she had breast cancer. So we were in the breast ward, and she really was at the end of her life. And I remember the one thing she kept asking me was, I just want my mom here. I just want to talk to my mom. I just, I think she could sense that really it was her final moments. And as a doctor looking at her, I could see it was her final moments, And I remember asking some of the nurses, can you help me get the number? And they said, there's no number of this lady of the mom on the file. We can't trace the mom. We can't trace like any close family members. And at that moment, I could have been like, it's fine. There's nothing I can do. I tried. But what I did is I actually went on social media and tried to track down the family members until I actually found the mom. And the mom was able to come. I don't think they were close, but I think obviously at the end of your life, there's certain things that you just need.
Yeah.
And the mom was able to come, and they were able to share a moment. And she literally died that day, midday. And that was the morning.
What's going through your mind when you reflect back on that situation as we speak? Do you still remember that sort of feeling?
Yeah. I just felt like this is where I need to be. And I know I can make a difference. And I know that I think I also understood that medicine and health goes beyond prognosis, diagnosis.
Exactly what I'm thinking.
Yeah, it's the humanity aspect of it that I think really attracted me, and I knew that I'm good here.
You mentioned you got a bit of professional help to chat to one or two people, just to, maybe potentially talk through some of the stuff that you've seen in different rotations. Going into medicine, you might not be inclined to go into trauma, for example, but you are faced with trauma, whether you like it or not. You
100%.
have to do a rotation there. Do some of your peers follow suit? Do peers and allied workers, colleagues, all talk to people, or do you feel that might be also a systematic problem where a lot of people don't actually chat to anybody and they just faced with these challenges and see these things and work through it by themselves?
I think one thing I'll always appreciate about the hospital that I did my internship is from the beginning, they had said that they do provide some counseling sessions for us with our sort of like in-house psychologist. So if we need that sort of debriefing, it's there. They didn't push it too much, but they alerted us that it was there. And I did utilize it. So that was very helpful. So I think one thing I would love interns to know is that really just ask within your hospital if they do provide that kind of service, where you can go speak to a psychologist if you feel like it's all too much. And then in terms of my sort of like peers, colleagues, did they follow suit? I would say yes and no. A lot of them followed suit when things got, I think, almost unmanageable. Because you have to remember there's the sort of like patient issues that you need to debrief. Oh, I experienced this, I saw this kind of trauma. But then there's also something that happens to you over time, things like burnout, which we've mentioned, that a lot of them didn't even realize they were burnt out until they started sort of like viscerally acting out, whether it be someone having a breakdown, a meltdown, or someone just sort of like going MIA, where you're just like, where's my colleague? And they actually decided not to come to work for like a long period of time because they weren't coping.
What?
Things like that were a reality. So I think I would love to alert interns about things like signs and symptoms of burnout. Those are very important things that they need to already be cognizant of now so that when they are in it, they can pick it up quickly and get the help that they need.
How old were you during was it in med school or was it an internship when you saw your first patient dying?
It was in medical school when I experienced death for the first time. I think outside of my sort of family and close relatives.
Correct.
Yes.
As a let's call it
as
professional.
a professional.
Yeah.
It was in medical school because I did my medical school in the Free State, and we already go into the hospitals in third year, and we start, talking to patients, and we start doing sort of our clinical work. And I remember distinctively, I was tasked a patient to clock. So we call them clocking a patient, where you basically take their history and you'll present that patient. And I got a patient in internal medicine, an old man. And I really, really liked him because he reminded me of my grandfather, who ironically had passed away also recently. And so I was, very invested, but I could see that he's obviously not doing well. He's really sick. I think he had like liver failure or something like that. He was jaundiced. There was a lot going on. So I went to the bathroom and lo and behold, the gentleman had passed away. And I remember just trying to wake him up because I don't think I'd grasped the concept at that point in time that he was no more. So I thought maybe because he's sick, he drifted off and he went to sleep. But then I'm looking at the monitors and I'm like, the monitors are showing that there's no heartbeat, or heart rate rather. And then I had to call the nurses. And then after that, I'm like, okay, so this profession that I'm in, as much as I'm trying to heal people and learn how to heal them, people actually die.
It's life and death, yeah.
It's a life and death situation here. Yeah.
What would shock people the most within their first 24 hours in a public hospital? As a med student, maybe potentially as an intern, but as an intern, you had that exposure before.
Yeah.
So in your third year, if another third year or fourth year student is listening to this, what would shock them most in their first 24 hours?
Yeah. I remember in my third year, fourth year in med school, we already started doing calls. They were never 24-hour calls, maybe a maximum of like a 10-hour call. And I remember thinking, goodness, I can do this, this is okay. Not realizing that when I got into internship, when they say 24-hour, 36-hour calls, I was like, okay, this is real. But pretty much a 24-hour, 36-hour call. And I'm saying 36-hour because I want to prepare our interns for the reality that they might have to go a little bit beyond those hours that they were thinking that they were going to do, 24 hours. I remember we never even had post-call. So what that basically means is after you call, you then go home and that day you're off so that you can recover from a 24.
Yes.
But some hospitals, you don't have that luxury because of the understaffing issue where you still have to continue during the day. And you only get to go home maybe around lunchtime, or you get to go home at the end of a work day, which is at 4 o'clock. And these are the realities. So to take you through a 24-hour, like I said before, you arriving, you're doing your ward rounds, you might not get lunch, you have procedures that you have to do depending on which discipline you're in. You have to be in theater. You have to, then when you're on call, you have to be literally either there in your ward, in casualty, or they're literally going to call you to say, okay, we have a patient if you have an opportunity to rest in between.
So a 36-hour call is typically you're starting at 8 in the morning.
Yeah.
You go straight through 8 the next day, and then you go another 8 hours to finish off.
That's correct.
What was your toughest call ever?
Okay. My toughest call ever was when I was in internal medicine as an intern. Unfortunately, I was on call back to back because we understaffed. So what that means is that I'm on call today to do a 24-hour. The next day I'm post-call, I do another 24-hour the following day.
What was your break between that 24-hour, the second call? How many hours did you get a break?
So if I started at 8 a.m. and I finished the next morning 8 a.m., then I would have that day off and I'd only go into work the next day.
And then you do another one.
Then I do another 24-hour. But at that particular time, one of my colleagues, I think they called in sick or something like that. And so I had to cover for them because we were so understaffed. And again, it was during COVID time. So I then did, I did 24-hour back to back.
3.
Yeah. So I did get an hour or 2 in between here and there to just catch a snooze so that I don't pass out and it becomes a legal case. But yeah, I did like 3 days basically of a call.
What do patients get wrong about doctors? And what do doctors get wrong about patients?
Sure. Let me start with the doctor first before I answer the patient one.
Yeah.
So doctors get wrong about patients is that patients want to get healed, which is true, right? They're at the hospital to be better. But I think what patients are looking for ultimately is that humanity connection with their doctor, that you see me, I'm in pain, I'm suffering, and you care enough to ask me things like, how are you? Some doctors don't do that. I mean, I remember there was a consultant who'd walk in and be like, right, charts.
Boom.
Boom, 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 done, out. No, hi, how are you? How are you feeling today? Do you think that we are doing all right in terms of your treatment plan? Do you want us to improve on anything? Nothing that...
No empathy.
No empathy
or at least form of empathy. Or
let me put it this way. Sometimes doctors are just not human-centric. They're pathology-centric or sick-centric. And we need to be human-centric. Because these patients, when I speak to them, a lot of the time they say, you know what, it's not even about getting healed. It's just the experience of the connection between the health practitioner and me. So I would say that our doctors really need to get back to the foundation, which is our humanity and empathy. I know it's hard in a system that sometimes just drags you and removes all of that. But if you stay connected to that, it will also give you a lot more fulfillment in terms of your work rather than just showing up as a zombie. Then in terms of what our patients get wrong with regards to our doctors is that, of course, they don't see the behind the scenes. What happens as doctors, how far we stretch ourselves. The fact that I did a 36-hour call, which is actually illegal, if you actually want to go into the nitty-gritty of it.
Yes.
And I did it and I pushed through is my way of showing the patient that I'm here for you and I'm here for this job.
This is my empathy.
This is my empathy. The fact that I can do a 3-day call, this is my empathy. And sometimes my empathy won't look like me greeting you or smiling because I've got 1,000,001 things I know that I have to do, but I'm here and I'm ready to do this job. So I think sometimes patients don't understand that doctors are faced with this complex. We are dealing with the pathology, but we've also got a system that's really choking the life out of us.
Have you gotten any experience in any way, whether that's locum, in private?
Yes.
Have you got a taste of private?
I got almost a full year of private.
Give me the 3 big things. What's the 3 big things that's different?
Definitely in terms of face value, private has resources. I don't have to run around and sort of try stretch one resource amongst my patients. I can use and complete whatever, medication, whatever health products or things that I need on one patient, and I'm good. And I can move to the next one. With public, sometimes you have to stretch your resources a little bit to try and make sure that all your patients somewhat get access to healthcare.
Okay.
But one thing I realized that I loved about public more than I loved about private was the fact that in private, I felt like everybody is just trying to get you. Let me preface that. So in public, if you make a mistake, for example, you've kind of got a team that will help you through that mistake. Let me put it that way. And it's a government thing. But in private, it's a you thing.
You're by yourself. Yeah.
You're by yourself.
And patient-wise, do you feel the same feeling from a patient?
That's the third one.
Okay.
Yeah.
Okay.
So I think it's unfortunate, but this is the reality. With public patients, a lot of the times really are at the mercy of the hospital and the health practitioners. So a lot of the times they don't complain about things because they're just grateful from what I've seen to get this help. With private patients, a lot of the times they are there to call the shots. They are much more involved in their own sort of like treatment plan, if I could say that. So if they're not happy with something, they'll say, no, I don't want this to be done. They also know their rights a lot of the times. I don't know if that's not a great thing, actually. Public patients tend to not know their rights. Yeah. So I think they give you a bit of a harder time in the private sector than the public sector, but I think it's sometimes warranted.
Busy with your MBA. We had a conversation about your MBA prior to today's session. Tell me why. Why are you doing an MBA? Is that something you would recommend for somebody that's unsure? Again, somebody that started internship, ComServe, they're unsure, they don't know if the clinical thing, they've gone through internship.
Yeah.
It's like, this is definitely not for me. They potentially wanted to specialize. I've chatted to so many patients in the past, or clients in the past that wanted to specialize, but after internship and ComServe, they're like, there's no way.
I think this is, if any intern or intern to be, if there's something they can take away from this conversation, is this question and why personally I decided to do an MBA. So I think one thing besides navigating hospitals, infrastructure, patients, and all these things, another thing that our interns are going to have to navigate is interpersonal relationships with their fellow colleagues. In the medical structure, it can tend to get a little bit toxic. Why I say that? For example, in corporate, you have clear structures on how to deal with, I believe, I could be wrong, how to deal with interpersonal conflict amongst, your colleagues. There's channels that you can go through to deal with this situation. With medicine, in my experience, it tends to be those channels are not so clear. So what do I do when my consultant is victimizing me? What do I do when the registrar who's supposed to be in charge of me or taking care of me is not teaching me as an intern? This is part of their job to do. What happens then? I had an experience. It didn't happen in internship. It happened when I was in my first year working as a medical doctor. I'm fresh out the box. I'm so excited. I'm so ready to work and earn my, my stripes.
Yes.
And I was unfortunately I found myself in a situation where I was under a consultant or head of department that was, I don't want to use too many words, but I'll just say ruthless to put it into. And I remember thinking, gosh, this person's such a terrible leader.
Yeah.
That's was my thought. I'm like, how can you be in charge of the whole department and all of us are like running away from you? We're all scared. We're all feeling like we're being treated like less than human, less than a colleague. And that moment for me was like, okay, I need to do something about this situation for myself. I know moving forward that I'm going to be a lead in healthcare. I don't know what that might look like. I think already by being an intern or medical, you are a lead in a community. And I remember thinking, but are leaders made or are they born? That was the question that was in my head. And I said, no, I think leaders are made. Yeah. Because if leaders were born, I wouldn't be dealing with the situation where my consultant is so inaccessible, is so difficult to work with. No, I wouldn't be dealing with that. So I said, what do I now do to equip myself to not be that for someone else when one day I'm in maybe their position? And the answer to that was an MBA for me.
Okay.
I said to myself, okay, but an MBA where, how, and what? And fortunately, there's this booming new thing of MBA in health leadership and in health care, where now they're specifically realizing that our health practitioners and health workers need a very niche MBA because the health system is so niche and so dynamic. And so that's where I got the inspiration to then further my studies in an MBA in health leadership, and I'm doing it through WITS. And it's been life-changing, to say the least.
Why?
The healthcare system is not what we think it is, as I think coming in as an intern, for example, because as an intern, you're coming in, it's me and the patient, and whatever it is that I need to do to take care of the patient and to get through the day. But the health system, especially in South Africa, is very complex and it needs very bombastic, if I could say, solutions. We need to really figure out our country's healthcare system and do something about the way it is situated right now. I think at some point we even touched on NHI and these things. What's your view on NHI? Yeah. Conceptually, love it. I think the concept is that everybody needs to have access to healthcare. Good. access to healthcare. And that is something that is correct.
Fair,
It's institution, in terms of our constitution, is correct. But now we're putting it in the backdrop of our country where we've got very systemic issues. Already we've got a 2-tier healthcare system where we have 84% in public, we've got the other in private. We've got these issues with our economy, we've got these issues with already things that are not working as we are now, and then we're trying to push everything into sort of like one barrel. I think will be problematic because we're not dealing with the issues at hand.
Very well said, yeah.
I don't know if that makes sense.
100%.
So we're not dealing with the issues at hand and we're thinking that NHI is the solution. And I don't think it's the solution. I think the solution is governance, leadership. The solution is really dealing with the sort of like foundational issues that we have in our country.
To tackle the foundational issues.
It's to tackle the foundational
100%.
Straight up. And then saying, okay, now that we've got some type of movement with our foundational issues, now let's bring in this element that is designed to ensure that everybody in South Africa has equal access to healthcare. I think that would be personally the approach, rather than doing it the other way around.
You are a social media influencer to a great extent. You've got over 100,000 followers on TikTok, for example.
Yeah.
Where did it start, first of all? And secondly, have you ever found that maybe a patient, a peer, a colleague has handled you differently because you are a social media figure?
Social media, I've always been in social media in some way, shape or form. I think I just hadn't refined my voice in social media. And fortunately, when I got into forensic pathology, I happened to just post 1 or 2 videos and the response was overwhelming. People just wanted to know so much about death and dying, so much about this very sort of like unseen world that actually a lot of us will come into face with at some point in time. You know, we're all going to lose a loved one at some point, and probably in an unnatural manner. And that's where you get to face forensic pathology. So that was amazing to see the response and just the curiosity that people have. And it was also affirming to me that my love for forensic pathology is not crazy, okay? My interest is not crazy. People also have that same interest. So that was a nice validation. I think in terms of the difference in treatment from my colleagues, I've had some interesting backlash, let me say that actually.
Is it?
Specifically in the forensic pathology world. Because it's such a sensitive topic, I think a lot of people weren't sure where I was going with it at the beginning. Because it's also confidential. You know, it's not secret, but it's like a sacred profession, if I can put it that way. Yeah.
So maybe explain what is some of the backlash that you
know, just like people saying, no, you shouldn't, educate people about forensics because the nature of the work deals with, criminal.
I get you.
There's a criminal element to it.
Get you,
so
yeah.
people were like, no, now people are going to know how we conduct this or how we do this.
Oh.
You know what I'm saying? So it's just like, it was a bit of a slippery slope at the beginning. But I think overall, after they saw the angle that I was going, which is education, essentially, I'm not trying to give everybody, tell them what we do to the T, but I'm trying to give families who really struggle with their loved ones going through postmortems, for example, just an insight so that they can get to know what's happening and have a sense of comfort through that process. Yeah.
What is medicine and specifically internship in South Africa taught you, Nox, as a person that no textbook ever taught you?
I think the word that comes to mind is resolve. What it taught me is that I have to be resolved in, for example, there are certain elements like we've spoken about that you can lose of yourself along the way because of the experiences that you have. But at some point you have to decide, okay, am I going to be bitter or am I going to be better? And I had to be resolved to decide that, okay, I'm going to be better. Yeah. I'm going to use whatever it is, all these experiences as stepping stones to the next. Whether it be to my career, whether it be to just me as a person evolving to be more empathetic and more understanding, that was basically something that I had to figure out for myself. Because it really is, we have a lot of bitter healthcare professionals out there. But I think an intern be resolved already at the beginning that no matter what it is that you're going to be facing, you've heard the challenges and the difficulties, but I'm resolved to be ethical, for example. I'm resolved to not lose myself in the process. I'm resolved to make sure that I get the help that I need when I need it. So all these things already, before you enter in, need to be in the forefront of your mind, so that when you face these challenges, you're not going to crumble, or you're not going to lose yourself, or at least you have channels to find yourself again.
We've seen some of our doctors actually immigrate.
Yeah.
Ireland, Canada, to name a few.
Yeah.
Do you find, or at least in your, let's call it your Oyakos or your circle of influence, where some of your peers have immigrated, and we feel we've got a bit of an edge when it gets to the international stage, purely because of these environments that, let's call it, our doctors have been exposed to?
Definitely. So we call it leeching, basically, leeching of our doctors, because I think the international space know that, first of all, South Africa, we've got the quadruple burden of disease, right? So we are exposed to things like TB, HIV, we've got violence, so these wounds we are exposed to, and it gives us that edge, it gives us that knowing quite earlier on. I remember one of my friends, she's in Germany. For her, she relocated because her husband got a job overseas, but she had performed so many C-sections here in South Africa as an intern that when she went there, she had performed more than the consultant that side. So she was teaching them a thing or two, you know what I mean? So the reality is we do have a skill set, and we are at the level, even our nurses, we are at an international level. And it makes sense why the international world is attracted to us. But also it makes sense why we're attracted to the international world. There's this promise that it's not going to be as hectic, it's not going to be as demanding. And I think that's attractive. Even salaries sometimes might seem attractive. But in my MBA and learning, for example, I remember one of the doctors went to go work in Canada. They are in my class. Actually, they are facing similar challenges that we face. The sort of like in the US, for example, with their healthcare system, it's not as rosy as, it's depicted to us maybe in television and film or whatever. People are struggling out there to access healthcare because they don't have things like health insurance, for example. So there's a lot. I know, for example, other things that maybe are not health related. The cost of living in Ireland is quite high. And if you don't go with that knowledge, you're basically being sold a dream or greener pastures. And a lot of the doctors that I've conversed with who are working in Ireland actually say that maybe it wasn't such a great decision for them to move because of, after everything is done, they've got a housing crisis in Ireland where, for example, if you're going to go there, you need to apply well in advance for a house, because for one house, maybe 5,000 people are applying for the same house. These are the dynamics that they're facing. So you might actually find yourself stranded and not have housing. These are things that we don't know as South Africans. We're just thinking, I need a job, first of all, because unemployment is real. I need a system that's going to be kinder to me. But then you're not sure about the realities that are on that side. So if you definitely want to move, it's fine. Just do your homework.
Do you find that some of your peers, look, definitely the unemployment situation in South Africa, I've seen it personally in a lot of our clients, where in the past ComServe was a given. And we've seen a lot of the guys, unfortunately, I think, according to some of the stats that I've recently seen in 2025, so this is last year, I think it was close to 2,000 doctors didn't get ComServe posts. That's quite a number.
Yeah.
Do you find, let's call it excluding unemployment, just the search for easy, do you find that a lot of them realize that it was never the pursuit to happiness, but it was rather the happiness of the pursuit? Where, let me explain, where the resolve, the grit, the hustle, the problem solving, the chatting to a person and helping them find their mother on social media because we didn't have a number, it wasn't captured, the system was broken. That changed you and that made you a leader in your circle of influence in your community, a thought leader, a voice. That is the happiness, potentially. And then immigrating and getting where all of this is taken care of, the comfort zone, the easy. I'm rather asking. And people realize, but this was never what I signed up for. It was actually the deeper things, the soft skills, the grind, the grit.
Yeah.
Do you find that is sometimes the sentiment?
Definitely. I think, sure. getting to the other side really, and unfortunately, nothing can prepare you. I think you can get knowledge, but it really shows once you're inside. It's like, okay, now my personality, now my ethos, now all these things are put to the test, and then I have to figure out which way am I going. That's number one. And then number two, definitely, I felt in internship that this was not something I signed up for. I definitely felt that. I thought that I'm going to be a doctor with my stethoscope, diagnosing, and, there's this thing. But again, walking in, you don't take into account the difficulties that people generally face socioeconomically and how they impact the work that you're doing. And I'm not even talking about the people. I'm also talking about the facilities that we're working in, the socioeconomic impact that our facilities also go through. Because the economics is that, do we have enough resources to do the job that we need to do? And sometimes the answer is no. And then you find yourself saying, but this is not what I signed up for. I was supposed to be a doctor who has all my drips, who has all my injections, who has all the charts and everything that I need to do the work. But now what happens when I don't have that? And every doctor is going to be faced with that sort of like question. Do I push and try to make best of the situation, or do I plan for the alternative?
You said after internship, you were like, this isn't what I signed up for.
Yeah.
Would you become a doctor? And this is sort of like my final question to you. Would you become a doctor in the South African system again?
Absolutely. I think it's like suffering and joy are like very close.
Cutting edge, like a double-edged sword.
It's a double-edged sword. I would, because I think, again, as a human being, as a person, I've personally grown a lot in this profession, and I discovered things about myself that I like, and I also discovered things that I don't like that I needed to work on, which I think maybe if I wasn't in this profession wouldn't have happened, or it would have happened later, and maybe I would have caused some damage along the way. And then that's number one. But then also the people, it is a people job. It is a people job, whether people like to admit it or not. Medicine is a people job because you interact with human. Well, maybe not in forensics, you know what I mean?
Touche.
But I mean, even in forensics, you have to talk to the families and stuff. It is a people job. And so I think for me, I get to learn a lot about people, their stories, their backgrounds. Again, just highlighting how diverse we are as a country. I mean, I get to speak to different people. I can speak to someone who's from, an Afrikaans background. I can speak to someone who's from a Shivenda background. And it's rich. It's a rich experience, So I think from that perspective, I would definitely become a doctor again 1,000 times.
Nox, thank you so much for your time. Thank you for your perspective, your insight. You're a mother of a 6-week-old.
Yeah.
We're currently in studio busy babysitting outside. So I know your time is valuable. You're doing an MBA in between as well. You're one of a kind. Thank you so much for sharing your time with us. I know it's such an important asset to you at this stage in your life and your career. Thank you also for the office that you represent, to all the medical doctors out there. Big shout out from all of us. I think we don't always get that insight and understanding as to what it is that you face. I've been privileged to do some presentations and inductions at some of the government hospitals in South Africa, and just to get a glimpse of the patient load and the environment is eye-opening. So thank you also for the office that you represent. And then also thank you to the listener. This is exactly why we started Money in Medicine, to educate, empower, and edify you, to make informed decisions. Also to get a bit of a glimpse as to what it is to be a South African doctor, what it is to be a doctor, and how it looks to serve people. And if you did find value out of this episode, or you've been checking us out for some time, I want you to please consider subscribing to this channel. It will allow us a bigger reach. It will allow us to get more Dr. Noxes on the podcast and the channel, to get their insights, their perspectives. And always remember, until next time, continue to plan the plan.